And welcome, everybody. Glad to have you back. My name is Matt McCullough. I'm the principal investigator for the Northwest Regional Telehealth Resource Center. And you're in the right place if you're looking for the session on telebehavioral health policy. So I will introduce our speakers briefly. First up today is Kwong, who's the executive director for the Center for Connected Health Policy, the federally designated National Telehealth Resource Center on Policy. We also have with us Christa Natoli, who is the executive director for the Center for Telemedicine and e-health law. And finally is Kyle Zebley, who is the senior vice president of public policy at the American Telemedicine Association, as well as executive director of ATA Action. So with those introductions done, I will turn the time over to Kwong.
Thank you, Matt, and thank you everyone for joining us today, and thank you to the organizers for inviting me to talk to you. I am going to be covering state telehealth policy in a post-PHE environment, which actually, for the most part, even though everybody's been talking about May 11th and the end of the federal public health emergency, a lot of the states have actually pretty much decided on what they're doing with telehealth now, and they've actually made that decision, even as far back as like 2 years ago. So really, I think probably the more exciting meeting will come with like our other two speakers of Christa and Kyle, but I'm just going to give you a general overview of like what states are doing, because there are a couple of interesting developments when you compare what's happening in a post-PHE environment to like what we saw among states with telehealth policy before COVID-19. So really quickly, as Matt said, I'm one of the Telehealth Resource Centers. CCHP is the National Telehealth Policy Resource Center, and Matt and his group, the Northwest Telehealth Resource Center, is one of 12 regional resource centers. So there are 14 telehealth resource centers in total. We all work very collaboratively together underneath an umbrella called the Consortium for Telehealth Resource Centers. 12 regional resource centers that cover specific states, and 2 national ones. Again, CCHP is the one on policy, and then there's TTAC, which is the one on technology, and they're based out of Alaska. I highly encourage you to reach out to your regional telehealth resource center if you have questions around telehealth. But really, you can kind of reach out to any of us, and we'll make sure you get the answer to your question, or at least routed to the right person who can answer that question for you. Couple learning objectives for today. I want you, hopefully after my talk here, you'll understand better the changes that states made to their telehealth policies in response to COVID, understand what the telehealth policy landscape might look like on the state level in a post-PHE environment, and get an idea of what states may do next regarding their telehealth policies. What are sort of like the pressing issues that states will be addressing that they haven't quite touched upon yet, or maybe they may be evolving or adjusting their policies as we go along. This is an overview of the responses to COVID-19 on telehealth policy, both on the federal and state level. And when you look at it, you'll see some commonalities as far as like issue areas that are touched upon, such as the modality that could be used, the type of providers could provide services via telehealth, location of the patient, etc. So while these are common issues that they touched upon, the policies may have differed significantly in how they address them. So states may have taken a different route to addressing like what type of providers can use telehealth and still be covered in their Medicaid programs than maybe what the feds did with CMS and Medicare. But overall, these were sort of like the common areas that you saw changes made in response to COVID. And as I said earlier, some of the states, or actually a majority of them, have already decided what their permanent policy is going to look like. There are some areas that were exclusively more on the federal level to decide and more on the state level to decide. An example of a federal level policy issue is prescribing controlled substances. I know a lot of you are probably wanting to hear about what happened with that, so I'm not going to get into it. Our other speakers will. And then on the state side, licensure, that's more of a state issue for them to decide. But for the most part, there's like a lot of overlapping of common issues here. So you'll see some of the repeated things of like they did this in Medicare, and you'll see like, they did this in Medicaid that look very similar. But there may also be different approaches that, states took than what the federal government may have taken. So these are some of the common state policy telehealth changes that we saw in response to COVID. When you're talking about Medicaid, again, very similar as far as like the area than what we saw in Medicare, in that they expanded the types of providers who could use telehealth and get reimbursed for it. I'm going to skip the second bullet for a second, but and go through the other ones. More explicit policy on FQHCs and RHCs. Before the pandemic, a lot of Medicaid programs were very vague or did not address at all how federally qualified health centers or rural health clinics, that they would be allowed to use telehealth and have those services be reimbursed by Medicaid. That was a little bit different, like during the pandemic. They became very more explicit in their policies of saying either yes or no, or only for these couple of things. So we saw a lot more clarity on what was going on with FQHCs and RHCs and Medicaid programs. Expansion of the type of services that will be covered if you use telehealth. Again, that was very similar to things that Medicare did on the federal level. And the big one, allowing home to be an eligible originating site. Prior to the pandemic, a lot of state Medicaid programs either had very limited policies where they allowed the home to be an eligible originating site where an enrollee can receive services via telehealth, or they did not allow that at all. That obviously had to be expanded during COVID-19, and we saw a lot of those changes made on the state level. Now, going back to that second point, that audio only one, the reason I skipped it was because I wanted to spend a little bit of time on this. Prior to the pandemic, if you asked anybody in telehealth, you asked them, like, is audio only included underneath telehealth? They would have told you no. And actually, quite a few states had explicit exclusions for audio only underneath telehealth, saying it was not part of how they defined telehealth. It was not included in telehealth policies. That had to change in response to the pandemic, and we saw Medicaid programs like Medicare allowing at least some services to be provided via audio only. So that was definitely a significant policy shift on the state level that we saw. Another big area, and one of the areas they said was exclusively to state policy to decide, was licensure. And what we saw in response to the pandemic was relaxing of licensure policies. Now, for the most part, before COVID-19, the rule of thumb was you need to be licensed in the state the patient's located. And that had to be relaxed when COVID-19 hit for a variety of reasons, because you needed providers. Perhaps there was a shortage of providers in certain states, certain specialists, but you also had people traveling and maybe they were stuck in states. So the licensure policies had to be relaxed in a multitude of states, and a lot of states did relax them. Now, as we are 3 years plus into the public health emergency, which is ending tomorrow, at least on the federal level, as I said, a lot of states have already decided on what they were doing with telehealth policy. So a lot of these temporary waivers have either been made permanent or they've expired. A lot of the licensure waivers have pretty much expired, but we have seen some changes as far as what their permanent policies are. And in general, what we've seen in Medicaid is a lot of states in their Medicaid programs have kept the expanded provider list. So when I mean expanded provider list, before the pandemic, you had your sort of usual suspects of like doctors and nurses, some behavioral health specialists, but you really didn't see a lot of allied health professionals like OTs and PTs. So they have now been included in this expanded list for a lot of Medicaid programs. A lot of services have been expanded as well too, and allowing the home to continue to be an eligible originating site. Now, it is still a little bit narrow. They didn't allow that for all services. A lot of Medicaid programs, maybe they were very specific on those types of services, but definitely saw more Medicaid programs allowing the home to be a place where a Medicaid enrollee can receive services. The most significant shift that we saw from like a pre-COVID Medicaid environment was the audio-only policies. Quite a few states have kept their audio-only policies, but a lot of them have been more limited. For example, what we saw with audio-only policies, they may have allowed it during the pandemic to provide a multitude of services, but their permanent policies may only really allow it for behavioral health or delivery of mental health services. But definitely that has been a significant shift that we've seen on the state level as far as their Medicaid policies. Licensures, for the most part, we are back to you need to be licensed in the state that the patient's located in general. But we have seen some advancements or some changes made in there. Biggest one being the creation of the registry, which Florida was the first one to do this, in that they created a registry that if you're on the registry, you're a good actor, you don't have to get a license, you're fine to provide services in Florida. You have to meet certain other requirements, but you don't have to get a Florida license. Also, they've made explicit certain exceptions. A lot more states are doing this. They're narrow exceptions, but these are exceptions that we did not see before the pandemic. And there's such things such as, well, if you are only providing services a couple of times a year, or if you've already established a patient-provider relationship and the patient happens to be within our state, we're going to let you provide services without getting a license if it's for a limited amount of time. So we're seeing these more explicit exceptions to licensure happen. And then the other more significant shift that we see is around commercial payers. So I didn't really talk about this before, but commercial private payer laws that are in states, the majority of states have them, but before the pandemic, the majority of states did not have an explicit requirement for payment parity. That's definitely a shift that we saw during the pandemic. Over the last 3 years, almost half the states now have explicit laws saying that you must pay the same amount, regardless of whether the service is delivered via in-person or via telehealth. Before the pandemic, there were only a handful of states that had that very explicit language in their state laws. That's definitely a shift now. We're seeing more states do that. Things to keep your eye on. Licensure policy, that's still developing. That's going to be interesting to see as states go around. Are they going to do more exceptions? Are we just really going to stick to compacts? What's going to happen with that? Medicaid changes. Is audio only going to expand a bit more? E-consult, for those who aren't familiar with it, e-consult is where you have, for example, somebody go into the primary care provider, they gather all the information and they forward the information to a specialist. The specialist responds back to the primary care provider and provides a, their opinion or their sort of like recommendations to treatment of that patient, and the care stays with that primary care provider. So it's an e-consultation that happens. That has been sort of a question with Medicaid programs on whether that they could cover that underneath Medicaid. And earlier this year, CMS has told Medicaid programs to send a letter saying like, yes, you can do that. You can cover that underneath the Medicaid program, but it's not mandated. So we may see, because that letter was issued by CMS, more state Medicaid programs allowing e-consult to be reimbursed. Interstate health, and how do you deal with that? For the first time, a lot of Medicaid programs are asking, how do we deal when the provider is not within our state borders? That's always been like an issue or a question that was brought up on around licensure, but now you have Medicaid programs trying to address that, and what do they do regarding that? And also the demand for more data and more scrutiny on like how telehealth is being used. We're seeing more and more state Medicaid programs either put together some sort of evaluation or task force to look a little bit more closely at the data and the use of telehealth. And then broadband and connectivity, that's pretty self-explanatory. That's also going to be a big issue on the state level, as well as on the federal level as well, and what we are doing about that, how we're addressing that to ensure nobody is left behind. So that is it for my part. This is our CCHP website. We also have a newsletter, and that is our email address. I'm going to turn it over next to the next speaker, who is Christa.
Thank you, May. Hello, everyone. My name is Christa Natoli. I am CTEL's Executive Director. CTEL is a 501c3 nonprofit telehealth research institute, and we focus on all the laws, policies, and regulations that impact the delivery of virtual care. We wanted to thank our host for inviting us today and making us part of this panel. Let's jump in. So these are the learning objectives for today. We're going to review PHE era flexibilities after May 11th, and then we're going to review flexibilities extended through December 31st, 2024 by the Consolidated Appropriations Act. And finally, we're going to talk a little bit about what you need to be aware of post-PHE and how you can conduct your own legal and regulatory audit. So I'm going to just take about a minute or two and talk a little bit about the DEA. Yesterday, the DEA issued a temporary rule regarding the prescribing of controlled substances when the practitioner and the patient have not had a prior in-person medical evaluation. And I'm going to leave the rest to Kyle because he's going to take a deeper dive into this. But on March 1st, we received a notice of proposed rulemaking for both the telemedicine rule and the buprenorphine rule. 38,000 comments were submitted, with the majority of those on the telemedicine rule. DEA closed comments on March 31st, and as all of us know, the public health emergency ends on May 11th. And so there was a concern by the telemedicine community that there could potentially be a gap in care, because the public health emergency would end on May 11th and DEA wouldn't have been able to propose a final rule before then. So yesterday, what many of you already know is that DEA issued a temporary rule that would be in place until November 11th, 2024, with the caveat that patients would have to be seen between May 11th, 2023 through November 11th of 2023. So they'd have to be an existing patient, and then all flexibilities would be allotted to them for the next year until November 11th, 2024. But I don't want to spend too much time on that. Kyle's going to take a deep dive into DEA. The next flexibility that we have to be cognizant of is that HIPAA flexibilities will be expiring with a 90-day grace period, officially ending on August 9th of 2023. As you may recall, when COVID was at its height, there was concern by providers that wanted to provide access to care to their patient populations, but were not fully integrated into telehealth platforms. And so the restrictions were lifted, allowing for platforms that were more user accessible. So platforms like FaceTime and WhatsApp, where you could engage with a patient directly with technology that they already had at their fingertips. You could go ahead and this PDF is fully accessible, and the links are there if you wanted to take a deeper dive into these flexibilities. Next slide. So what happened in December of 2022 is that we received the Consolidated Appropriations Act, which allowed for the extension of the telehealth flexibilities through December 31st, 2024. Sorry, that's a typo. And the main pieces that we need to be cognizant of that will really impact the virtual care community as it applies to telehealth is the issue of reimbursement. So we just addressed that the two flexibilities that were not addressed in the Consolidated Appropriations Act that thereby extended flexibilities of the pandemic era were privacy and security through HIPAA, and then DEA, but DEA was just addressed yesterday by their temporary rule. Now we're going to address flexibilities that were extended until December 31st, 2024 through the Consolidated Appropriations Act that was passed last December and signed into law by the Biden administration. So the first question that everyone has is, well, how are we going to continue to get reimbursed? Are we going to have to follow pre-pandemic era requirements for Medicare reimbursement? Help us understand that. And so what you need to know is that the Consolidated Appropriations Act removed geographic requirements and expanded originating sites for telehealth. So that will stay the same. There's a delay in in-person requirements for Medicare reimbursement for mental health services. So as you may remember, in December of 2021, the Consolidated Appropriations Act passed some language that would require that a patient that is being seen for mental health services would have to be seen over the last 6 months in order for that practitioner to be able to reimburse for that encounter. And that, of course, is delayed until 2025. And then the third major requirement is allowing for the furnishing of audio-only telehealth services for Medicare beneficiaries. This is a big one, especially for those that live in rural areas that have either low Wi-Fi and broadband penetration into their geographic region, or those that are suffering from a lack of cellular data and unable to connect to the internet. So this is something that a lot of advocates had really campaigned for, to make sure that audio only was still going to be allowed. The rest of these flexibilities, as you could see, are listed here, and many of you have already reviewed these in detail, but they're available in this slide if you'd like to go back and review, and I'm happy to talk to you one-on-one about them. The next up is that we have extended the Medicare and CMS has extended the physician fee schedule. So as many of you know, there was a limited number of services pre-COVID that would be reimbursable under telehealth. The Consolidated Appropriations Act extended those flexibilities into 2024. And there is a link right here that will tell you all the services that are fully reimbursable, but that is extended until 2024. And so I believe that there's around over 244 codes. So the question is, okay, great. We now are one day before the public health emergency expires. What do we need to be cognizant of? So CTEL put together a post-PHE checklist, and this is what we recommend for organizations to consider. You need to make, the very first one is to be cognizant of your platform that you are using, making sure that it is compliant with HIPAA. If you don't have that, that is really a non-starter. So make sure that if you are going to be engaging in virtual care services, that the platform that you are using is HIPAA compliant. Second, we addressed this earlier, that DEA just released a temporary rule for the prescribing of controlled substances and amending the Controlled Substances Act and Ryan-Haidt Act of 2008. So we will go ahead and just leave that to Kyle to take a little bit of a deeper dive into. And then the next piece is, if you prescribe controlled substances, and I apologize, I'm just going to go on mute for 1 second. And then if controlled substances, if you prescribe controlled substances in, I'm so sorry, 1 moment. All right, the pleasures of working from home. So if you prescribe controlled substances and DEA's prescribing rules do not go into effect until May 11th, are your telemedicine prescribing practice compliant with Ryan-Haidt? The next one is, have you reviewed the list of Medicare telemedicine services that are eligible for reimbursement? And have you reviewed the list of Medicaid telemedicine service codes that are eligible for reimbursement in the states where you deliver telemedicine services? And then just a continuation of the post-PHE checklist. The next piece is, we really have to determine about coverage parity and service parity. So the question that I often ask is, if you are a system, have you evaluated whether the states you deliver medicine have policies on coverage parity, service parity, payment parity for Medicaid and commercial plan reimbursement? That's a big one, because if you don't know that, that could impact your reimbursement opportunities. Second, have you reviewed contracts with commercial payers to determine potential changes in reimbursement and covered services? And then finally, have you engaged with your organization's payer strategy revenue cycle leaders to negotiate sustained reimbursement with your contracted payers? Next slide. So we've talked a little bit about the PHE checklist, and we talked about the flexibilities that are ending, the flexibilities that are going to continue until December 31st of 2024. Now, the question is what about permanency? Permanency is important because, we want to move past this kicking of the can and really have something to rely on. That's going to impact the entire healthcare ecosystem. Health systems, providers, they need to know, are we going to be able to continue to see patients in this manner? Are we going to be able to continue to see patients and get reimbursed in this manner? And that's important to have that confidence as a health system to understand where telemedicine is going and where those rules and regulations are going. The last piece of this is talking a little bit about future forecasting. So CTEL did some research and released it to Congress, CBO, and to the administration and the White House in December of 2021. And with final completion in 2022. And what we looked at is we wanted to see, what does telemedicine cost the federal government? When we started this research, it was 5 years prior, and COVID was not even something on anyone's mind. And we wanted to determine what the cost of telemedicine was in efforts to provide data to the CBO, to potentially give the CBO data to essentially determine how much telemedicine was going to cost the federal government, just to score it. So what we looked at is we looked at 1.43 million telehealth encounters. There were all 50 states were represented, and every payer was represented. So Medicare, Medicaid, commercial payers, commercial plans, and self-pay. And what we found in this 5.5-year study is that telemedicine was either cost savings or cost neutral to the federal government. Out of the 1.43 million telehealth encounters, 800,000 of those dealt with severe mental and behavioral health issues. That was the top diagnosis out of the 5 diagnoses that we did see. And telemedicine, and then in terms of demographics, it closely represented US Census data, looking at age and gender and ethnicity. So that was important because we were able to see that it was a good representation of the overall country. And then finally, children accounted for more than 1/3 of patients with mental and behavioral health diagnoses. And that was startling, but it showed that the research that we were able to conduct over the last 5 years found that if you use telehealth and you were able to provide a medical specialist specifically for mental and behavioral health, you had greater healthcare outcomes for the patient being treated, especially within pediatrics. So why is this important now? So we have this research. Congress has been very direct that they are concerned about the issues that they're concerned about prior to making these flexibilities permanent are issues dealing with fraud, waste, and abuse, and then also issues dealing with healthcare equity. Our data, which was done that met all academic rigor standards and was done agnostically, shows that telemedicine did not negatively increase the budget. And so it gives the opportunity for us to hopefully remove those originating site barriers in 1834M of the Social Security Act, and then to essentially make these waivers permanent at the end of December 31st, 2024. So CTEL thinking about what we need to do as a community in terms of our research and our policy is, we would like to continue working on research that backs good policy changes and present this research to key committees of jurisdiction, but then also to CBO. CTEL is working to extend this research beyond what we initially found in our first set of data that we released in 2022. And we're going to continue this research into 2024, hopefully being able to provide Congress and CBO and the administration with access to good information to show what telehealth looked like post-PHE in terms of cost to the federal government. And we would love if any organizations that are on this call or health systems or academic medical centers would like to contribute to this data request. You can contact me at the information that is listed on this slide. So thank you very much for inviting us. And next up is Kyle with ATA. So take it away, Kyle.
Great. Thanks so much, Christa. And obviously, it's a real honor for me to be here with such an esteemed group of fellow panelists. Obviously, really, really great contribution so far, and hoping to just add to some of the knowledge that's just been shared. And what we thought we would do, given the timeliness of the latest news, is that we really get in deep in my presentation on issues concerning the Ryan-Haight Act and the remote prescription of controlled substances, because there obviously has been the in-person waiver in place now since 2020, and we're coming towards the end of that waiver with some recent news developments that we've kicked the can a little bit. And so we'll definitely get into that. And again, as was noted, Kyle Zebley, I am Senior Vice President of Public Policy with the American Telemedicine Association, which is celebrating its 30th anniversary this year. And I'm also Executive Director of ATA Action, which really handles our advocacy and lobbying specific issues. So what is the Ryan-Haight Act? In essence, it's a law that was passed back in 2008 that mandated an in-person examination prior to you being allowed to prescribe controlled substances remotely via the internet, via technology. There have long been exceptions in place since the passage of the Ryan-Haight Act into law in 2008 that have allowed for certain circumstances for some variation of remote treatment. However, there had been this severe limitation on the ability to prescribe remotely as the country entered into the public health emergency and the pandemic early in 2020. A couple of things to keep in mind. Of course, the reason why a very sad story as to why the Ryan-Haight Act was passed into law was the story of a California student who was able to obtain controlled substances for diversionary inappropriate purposes back in 2001. This resulted in the passage in 2008 of the Ryan-Haight Act. However, something really important to call out is that when Congress passed the Ryan-Haight Act into law, they envisioned the ability for licensed medical professionals in good standing that had prescribing authority to register with the DEA through what is envisioned to be a special registration process. And though Congress had sketched that out back in 2008, and though they subsequently in 2018 and through other various letters and correspondence and committee reports have instructed the Drug Enforcement Administration to do a special registration rule, that special registration rule has never come to fruition. In essence, we're now 15 years past the passage of the Ryan-Haight Act, and the DEA has not stood up the ability for licensed medical professionals to prescribe remotely without that in-person burden and barrier. This was certainly the case in the beginning of 2020. There was great frustration among advocates for telehealth, among mental health advocates in particular, that more needed to be done to ensure appropriate access to controlled substances. And we were able to, the ATA and the telehealth community broadly, were able to communicate with the Trump administration and Secretary Azar's Department of Health and Human Services and other key decision makers early in the pandemic to talk about the real barriers to remote access to care. One of the top requests at that time, if you were trying to make sure that patients had increased access in the comfort of their home or wherever they might be located, to make sure they had appropriate access to clinical care, one area was to waive the in-person requirement under the Ryan-Haight Act. And so correspondingly, they did so in January of 2020, and that in-person waiver has been in effect ever since. As was noted earlier by Christa, the DEA did a couple months ago release some draft rules as to what the permanent framework would be post the end of the public health emergency. And they gave the public a very tight 30-day time frame in order to respond to those draft rules. And it really seemed like to us a very rushed process, given the fact it's been 15 years since the Ryan-Haight Act was passed and the special registration rule was mandated by Congress, given the fact that we had been in the public health emergency by March of 2023 for 3 full years. It seemed very rushed to get these rules out the door, and seemed very much to be in response to President Biden's announcement earlier in the year that May 11th, tomorrow, would be the end of the public health emergency. And so even with that very tight time frame, 38,000 comments were submitted to the DEA, to their rules. We had there were fundamental aspects of the rules that we had big problems with, namely the reimposition of blanket and flexible in-person requirements. And there were some items at the edge that made the rules more accessible than what had been the status quo prior to the pandemic. But at the end of the day, it wasn't really taking on board and putting forward a special registration rule. It wasn't allowing for some kind of continuation of the pandemic era status quo. And so we thought it was a big step backwards, and we were very concerned as to what they were going to do. As Christa noted, we have been able to see some favorable developments, but at the end of the day, it also is just a kick the can maneuver. And we'll talk about that in just a minute. Not going to get into the weeds here, just so that we leave ourselves some time for questions from the audience. But again, in terms of the DEA's draft rules, and have not taken an effect, and indeed might be rethought, there were a number of aspects that we had some pretty big concerns with. But at the highest level, the biggest concern, as I had mentioned, was that reimposition of an in-person requirement. We really jumped into action as a community to make sure that we were heard and listened to. And as soon as the rules came out, we actually were very fortuitous as the ATA to have our annual conference in San Antonio. And so we pulled together a listening session that was really designed to help inform our eventual 12-page, heavily cited comment letter in response to the rules. And we were privileged to have a representative, a lawyer from the Drug Enforcement Administration, down there in person with us in San Antonio to not only listen to this full listening session and take detailed notes, but actually sit and talk to our members. And obviously he was limited as to what he could provide to our members, but he was very much in intake mode. And I'd like to think that that, combined with some other actions we took and the actions that so many others took, tens of thousands of others, that we were able to really give DEA pause, and it resulted in the positive actions from yesterday. So we definitely, as the ATA, did a lot of listening sessions. We did as many stakeholders calls as possible to get on the same page with our other like-minded stakeholders. We really hit the ground running in terms of further meetings with other folks in the administration at the Domestic Policy Council housed in the White House, with folks at the Department of Health and Human Services. Definitely communicated directly as best we could to the DEA, other than what we did at the conference. We sent our comprehensive letters. We were featured in media coverage, of which there was substantial media coverage. And so I think our advocacy efforts, which really set us off at a sprint when the draft rules were released, were effective. And here's just an overview of some of the various paid advertisement, a first for ATA Action, which we just founded at the beginning of last year, the paid advertisements that we did in various periodicals and online publications exclusive to the DC market, to hopefully, again, build some momentum to urge DEA to reconsider some of the directions that they took. As we talked about yesterday, we got the announcement that the DEA is going to extend the pandemic era flexibilities for another 6 months till November 11th of this year, and then grandfather in and give a year of grace to come into compliance with whatever rules they come up with between now and November 11th, those patients for another full year. So if you've established a patient-provider prescribing relationship over the last 3 years up to November 11th of this year, you'll get that 1 year of grace from November 11th, 23 to November 11th, 24 to come into compliance with whatever the DEA rules happen to be. We hope that they fundamentally rethink and move away from those blanket, inflexible, clinically inappropriate in-person requirements that don't allow for the full potential of telehealth and will sever the continuity of care for a lot of underserved Americans that had hitherto not had access in the way that they've been able to do in the course of the pandemic. So that's our hope, but we could, well, of course, wait to see what happens. So it's we live to fight another day. We'll have 6 months to continue to make our case alongside other telehealth advocates. So with that, I'm going to go ahead and turn it back to our moderators and hosts. And it's a real honor to be here and looking forward to any questions that might be coming in from the audience.
Great. Thank you, Kyle. Thank you, Christa and May. Wonderful presentations and so much content, so much to consider. We do have a lot of questions in the Q&A, so let me get to those. The question that really can't be avoided with the most votes, any chance of getting a national license? So I'll leave that up to you to decide who to go first.
Well, I'll just say I believe for the time being, even with the advances that we've seen and the various measures to break down interstate barriers to care that May had mentioned, I still think for many years to come, we're still going to have to do the hard work of going through and either see states adopt licensure, flexibility laws, registration laws, or the compacts. There's a positive role the federal government can play in encouraging states to go down that direction. But from my perspective, I don't see a one-size-fits-all federal preemption of state licensure law.
I'd agree. I think that if we were going to see that, we would have seen something during March of 2020. And we saw the exact opposite. So Kyle's right. We have a really great nurse licensure compact, and the Interstate Medical Licensure Compact has 39 states that are part of it, with 5 more pending. So, you know, I think the closest we're going to get to licensure is a really great interstate compact, national licensure.
No, that's my simple answer. No. The one thing that I could foresee happening, at least over the next couple of years, is perhaps an exception of when a public health emergency is declared, just simply given the experience of COVID. But, you know, a regular national license, I'm not seeing that for at least the next couple of years.
Yeah, great. Thank you. So May, you talked a lot about state level legislation and policy. In the Northwest region, we've seen a lot of state legislatures trying to solve workforce issues, especially with behavioral health. And one of the ways they're trying to do that is by making it easier to either be licensed in the state or not even have to get a license. So that being said, the next question says, will increasing availability of telehealth for mental health providers working remotely change the need for agencies to employ full-time on-site staff? What are your thoughts?
No, I don't think so. So one thing that people need to understand, though, even though telehealth is becoming more available and is utilized more, it is still a choice. So patients will still have that choice of whether they want in-person or services via telehealth. And while we saw an increase of telehealth usage and utilization during the pandemic, especially at the very beginning of the pandemic, we also saw a drop from those high levels as well. So there is still like a significant portion of the public out there who prefer to receive their services in person. And telehealth, while we are all telehealth proponents on here, I think we all agree it's like it is not appropriate for every single situation. So you're always going to need those in-person services to an extent. So I don't think there will be this competition where you're going to eliminate like the need for in-person services. You're always going to need those in-person services because certain things just can't be done over telehealth. And a lot of patients probably are just going to prefer seeing their provider in person.
Kyle or Christa, anything you want to add to that?
Well, I just think May said it wonderfully. I think there are lots of circumstances where telehealth is appropriate, but it needs to be the choice. It needs to be clarified that it is appropriate by the provider in question under the standard of care and under the terms of their license. And so while it will help augment workforce shortages, it's not in and of itself a cure-all, a panacea, or appropriate in every circumstance.
Yeah. Well, the next question that really can't be avoided if you've been to any telehealth or healthcare conferences recently is what policies are being implemented around AI and ChatGPT when it comes to telebehavioral health practices?
Well, I believe Washington State actually has a provision within its medical board policy that addresses AI. And I think it's one of the few states that actually addresses AI. We're going to, CTEL is going to be addressing this issue formally in the next coming weeks at our upcoming meeting. But, the question is, are you establishing a practitioner-patient relationship using these algorithms? Most telemedicine companies are using these algorithms already. They're already integrated into the platforms. The other questions are like, where does medical liability, who holds medical liability? Is it the developer? Is it the practitioner? I think mostly what we will see in the next coming months and years is that ChatGPT and these AI tools will be just that. They will be tools, and they will be something that a provider can potentially use to assist, but it's not going to take away that practitioner-patient relationship. States are very specific on how you have to form a practitioner-patient relationship. They even go so far as to say that a questionnaire by itself is not sufficient. So that seems that even though AI might not necessarily be discussed in each state policy, there is some language that would suggest that that is not a sufficient way to engage with a patient.
And I would just say that definitely seeing developments come pretty quickly at the federal level as well, with the administration putting forward its AI Bill of Rights, which will obviously have an effect as to how it's deployed in the healthcare system. And also the Department of Health and Human Services Office of National Coordinator is putting forth a set of rules with feedback due by June on how certain provisions of 21st Century Cures Act will be implemented, particularly in terms of algorithmic questionnaires. So a lot of exciting developments. But I think Christa hit it head on. I mean, at the end of the day, AI, like the rest of the modalities available in telehealth and virtual care and through the use of technology, is a tool to be deployed, not an end in and of itself.
Great, thank you. May, anything you want to add on AI?
I think both Christa and Kyle said it all, but also keep in mind, it's like policy develops really slowly. So while AI is being talked about a lot now, as Christa said, there's not a lot of it developed around. And I mean, look how long it took to develop a lot of telehealth policy. So
yeah, good point.
Fantastic point, May. Fantastic point.
So we just have 1 minute left. Let me get to this next question. And I'm going to add a little bit to it. But the question is, do you think more insurance companies will start recognizing telehealth as a needed option outside of the pandemic? And I just want to add maybe the reimbursement piece to that. Outside of the pandemic, what's going to happen with reimbursement?
I think it's here. Obviously, it'll fluctuate. Most providers, actually, most commercial insurance providers actually were way ahead of the curve and had offer a lot of modalities prior to the pandemic that only has grown over the last 3 years. You're going to see an ebb and flow. There's going to be tension between medical professions and the payers about what gets paid and at what rate. And what's covered. But I think most payers now have come to terms with the fact that this is what their beneficiaries want, and this is a way to squeeze efficiencies out of the healthcare system otherwise.
I kind of wonder if we're going to see some type of required standard for AI before it's reimbursed. So if you think about it, not all telehealth models or platforms are created equal. Some are way more inclusive and offer medical peripherals and diagnostics, and others are more simplistic. And depending on the medical condition being treated, some platforms are required where others might actually be medical negligence if you use them. So the question is, the standard of care for telemedicine is the same as that you would use in medicine. So how are we going to make sure that any platform or artificial intelligence algorithm that we use is equivalent? Because AI could vary drastically based on the data that they have as part of that set. And so that's important. And that's something that we need to consider is there going to be some type of standard before the reimbursement?
May, anything you want to add?
No, I think actually that's a good note to end this session on. So thank you for doing that.
Okay, well, we will wrap up then. Thank you all so much. Excellent presentations. We've had a large audience. I've seen over 350 people listening and participating in the question and answer. So thank you again. And we look forward to seeing everybody back. Enjoy a few minutes for lunch.